Mr. Varney.
As the court pleases. My Lord, we're still busy with the expert witness, Dr. Steve Naidu, the forensic pathologist. With the court's leave, we'd like to return him to the stand.
Please. Just want to remind you, Doctor, you are still under formal oath?
Thank you, my Lord.
Yes.
As the court pleases. Dr. Naidu, are you comfortable?
Yes, thank you.
Good. So, Dr. Naidu, if you recall, we were traversing your expert report yesterday, and we were on page 11 of your report and about to start at paragraph 32, dealing with cause of death. And in that paragraph, Doctor, you suggest that the consequences, that the cause of death was the consequence of pressure upon the neck, and it should be considered the consequence of a neck constriction rather than actual hanging by suspension, as suggested by Professor Gordon in the first inquest. And you go further to say that this cause of death is not disputed. Can you elaborate on that conclusion?
Yes. This is something I considered quite important in that we need to dissect out this issue of the cause of death. Professor Gordon repeatedly held to his view that this was consistent with hanging. And his argument was that he was saying consistent with hanging, but he was not saying, he was not implying, and it was not his place to make a finding whether this is homicidal or suicidal or accidental. I think this needs to be clarified because clearly this wasn't a case of hanging. Hanging is usually when the body is suspended and the neck is strung and the neck is constricted by the body's weight pulling against a ligature suspended from a higher position. And that is the body weight factor. In this case, it was not the body's weight at all. Apart from, and I'm not even referring to the engineer's determination of the pull on the ligature. I'm just looking at my own observations that the possible only traction on that ligature was the tilt of the head, because most of the body was supported, perhaps 80 to 90% of the body, 90% or more was supported. It's clear from the nature of the twist of that ligature that this was a strangulation. It was a ligature strangulation. Here too, stating that it's ligature strangulation doesn't imply that we doctors are making a finding of homicidal or suicidal. That would be something that context and the scene examination will show to the court, or will suggest to the court. So it's clear that the ligature was extremely tight. It was said so in Gordon's scene observations, Professor Gordon's scene observations, and in his oral testimony. Extremely tight, that's the word that was used. So this is not a hanging. This was a strangulation by ligature.
And Doctor, would you agree that if this was a self-inflicted, that it would have been considerably easier for the deceased to have stood against the grille in a standing position and then simply turned around until the ligature was tight enough?
Exactly. I've seen several of these, several of these deaths, not domestic mainly, and several also in cells. And this is the first time. It's an extremely unusual form of a ligature contraption. I have seen one other unusual form that was not, I don't think it was really resolved. A similar, where there's a question about whether this was self-induced or whether this was autoerotic sexual type of death. But this as a hanging in a cell, certainly not autoerotic or anything like that. This was extremely unusual. And I agree that having visited the cell and seen other cells too, there were at least 3 or 4 or 5 other more likely, more accessible positions of suspension should the deceased have wanted to hang himself.
Yes, it is puzzling indeed that if it was self-inflicted, the deceased chose to use perhaps the worst position to do so, namely the bottom rung.
Or the most difficult one to contrive.
Exactly. And of course, we're duty-bound to put up a version for the court's consideration. And it strikes me that one possible explanation is if the deceased was carried into the cell, that would have been the most convenient and easiest situation to place the deceased in, simply because it would have required the least effort, assuming there's a homicidal explanation for what happened.
I would agree.
Doctor, moving on, you make reference to the evidence of Dr. Biggs on page 12 of your report. You say the mechanism of death in this context and dynamics would likely have been airway compromise, as testified by Dr. Biggs.
Yes.
And just to remind ourselves, my Lord, at page 793 of volume B, Dr. Biggs in his report said cause of death was by suffocation, not sudden arterial occlusion. Could you explain to the court
Yes.
what Dr. Biggs was referring to?
Yes. Forgive me. I just want to move this so that there's no interference with the microphone. Dr. Biggs indicates a difference of opinion as to the physiological mechanism, whereas Dr. Biggs speaks about airway occlusion and Professor Gordon about vascular or blood vessel or arterial compression. In my view, and with due respect to both of those colleagues, that would be academic. Whether the death, the ultimate death, was due to the arterial blood stopping or to airway compromise, it wouldn't matter, in my view. What matters is how the ligature constriction with the multiple twists was created. So, whether it was due to the carotid body stimulation with pressure on the neck, that's a third option, or due to airway or vascular compromise, it didn't matter.
Doctor, I must ask you, your conclusion that the anatomical mechanism of death was that of a consequence of pressure upon the neck.
Yes.
Does that exclude other potential causes of death?
No. I think one has to bear in mind, and this is, and perhaps we will be coming to this, the relative seriousness and the weight of these injuries, because I was of the opinion that the abdominal and chest injuries were potentially very serious. So there could have been another cause for this death. And although Dr. Biggs testified to having seen petechial hemorrhages in the eyes, which Professor Gordon didn't describe, and it would suggest that the ligature was applied whilst he was alive, petechial hemorrhages. But if Prof. Gordon didn't see it and Dr. Biggs saw it, I must say it then is, I'm not completely certain whether Dr. Biggs had seen the right finding, because you can get artifactual spots in the eye that can appear as petechial hemorrhages. We must accept that Prof. Gordon, that was his area of speciality. Even in forensic medicine, but asphyxial and neck injuries was his area of speciality. The problem we have, of course, and I have, is interpretations of the findings, not the findings he made. So coming back to that point about whether we can exclude any other cause, one can't.
So these potential causes which we will explore are not necessarily mutually incompatible?
No, they're not. In other words, if I may just extend that, just while we're at that, it is possible if very early after death from another cause that the deceased could have been, we can't exclude that the deceased could have been put into a ligature twist in that way. It can't be excluded. Despite the fact that, give me my lord, I should be referring, despite the fact that in the examination of the neck, there were 2 bruises that Prof. Gordon found, a small one underneath the right side of the mandible, and one at the anterior edge of the sternomastoid, this muscle here. But those both it could be possible that both of those may have occurred as a result of the constriction at the right side. So in other words, the thickening and the scrunching and the bunching up of that noose on the right side can cause an injury at the edge of the jaw. Now, we don't know what size that bruise is. From the appearances of his description, it's a small bruise, and one cannot exclude completely that it was a post-mortem or immediately after death occurrence. I'm not sure if I'm clear on that.
Yes, I believe you are clear.
Thanks.
In the last line of that paragraph, my lord, that's still the same paragraph, 3rd paragraph on that page, you state the following: the effects of venous or arterial obstruction would have been minimal, if any, whilst the possibility of terminal reflex neurogenic cardiac arrest cannot be excluded. Some technical terms there. Can you explain in layperson terms what you mean by that?
Yes. With pressure on the neck from a ligature or from strangulation, ligature strangulation, or by ligature hanging, slightly 5 different terms, or by someone being strangled, or by someone being struck across the neck. Besides, there is a third solid possibility of a mechanism aside from airway blockage and arterial and venous blockage. And this is because of a sensitive pressure nerve receptor in the carotid artery, where it bifurcates one into two. It branches. At that branch, at the bifurcation, at that branch is a sensitive pressure receptor, and in some instances, pressure on that, well, we know pressure on that induces the heart to slow down. It's a physiological reflex. I don't want to go into that any further. But we know that in some instances, the rapidity of death from people who are just sometimes playfully touched or pulled by the neck in states of excitement or tension, sometimes during love play, that they call it, people have known to have died. And because it's so well described and regularly seen or regularly contemplated, we believe now that it's a well-established cause of death. Acute neurogenic cardiac failure, that when that nerve receptor, precious receptor, is stimulated, it causes the heart to slow down and stop, and a person can die. So it's the third main cause.
Right. So if I understand you correctly, Doctor, you're saying that that maneuver, that constriction of the neck, could possibly have caused cardiac arrest?
Yes. Yes.
And would I be saying, and listening to you, would I be correct in saying that, in fact, cardiac arrest could have occurred under torture as well, given the kinds of physical abuse he had been subjected to?
Yes, because it's postulated that under states of extreme tension, agitation, and distress, the sensitivity of these areas, spots, are increased. And for example, this is what happens in anesthesia. When anesthetics suppress all the sensation so that you can press on that without any deep anesthesia, suppresses it so that you can press on that without any effect. So that's just for the court to understand that physiology. So in states of deep agitation, great tension, great distress, the physiological sensitivity of these nerve receptors are heightened. That's what it's believed. And that's what is believed. And we strongly hold to that view, and most pathologists at this stage. So this deceased was probably in that category of extremely heightened distress and physiological excitation.
And if it was a cardiac arrest, would it necessarily have been picked up at the post-mortem?
No, there would be no signs of that. No signs that was the mechanism. So you'll find nothing to indicate so. Yes. May I?
Yes.
At this point, my Lord, because I had, and I must thank the court for an opportunity to go through, because there's a lot of difficult readings of text of the the transcript, very faint, so I had made notes and I needed to go through that, and I thought at this juncture, talking about the ligature and the neck and the pressure to the neck, I need to draw attention to additional abrasions that were seen, some of them on the neck that Prof. Gordon describes and he testifies to. Additional short linear abrasions, mainly on the midline on either side, or on the right side of the neck, And in two positions on, you want, I'm not too sure if the, thank you for the photo, I'm not too sure if that photograph actually shows it at all. It's very difficult to see because the post-mortem suture on that unfortunately occludes or masks that entire front. But on the right side of the neck, that was below that transverse indentation, at the right side of the neck in the midline, there were at least about 3 or 4 linear abrasions. I need to point out that Prof. Gordon asserted repeatedly that it's usually due to the deceased's own fingernails, and I have seen that as well, when they try to adjust the ligature on the neck in suicide. But what I'd like to also add to that, it's also seen where persons are trying to free themselves of a constricting ligature. So whilst Prof. Gordon, in two positions, I believe, talks about the deceased attempting to adjust the ligature on his neck, implying in self-infliction. But it's also seen, or in fact, more often seen, in cases where the deceased himself or herself is trying to loosen the ligature that's constricting him or her in strangulation, homicidal strangulation.
It would stand to reason, at least from a layperson's perspective, that if this was self-inflicted, there would be no cause for the deceased to try and loosen the ligature. In fact, the opposite would be true.
Well, yes, that's correct. Although Prof. Gordon talks about adjusting the ligature, making it more comfortable, even that is a bit far-fetched, if I may say. One would expect it to be seen in the desperate attempts to free themselves from a ligature that they were not intending.
Yes, and the kinds of injuries from adjusting, which presumably wouldn't be a vigorous activity compared to an activity where the deceased tries to release himself.
Yes, that the
really
second would be
difference.
Yes, the second would be a frenzied attempt to free themselves.
Dr. Nader, thank you. Let's move on to your next point. That's at in the final report. At paragraph 33 on page 12. You say it cannot be decisively determined whether this was a self-inflicted neck constriction or whether it was caused by another party. Can you just briefly explain to the court why you reached that conclusion?
Yes, thank you, my lord. From the medical evidence alone, it's difficult or not possible to determine whether this was self-inflicted or constructed by another party, this ligature around the neck. That is no doubt, he was found with this ligature around the neck. We aver that this is ligature strangulation, this is not hanging, but we cannot say that this was not self-inflicted, nor can we say that this was not external tying by another person, the homicidal type, from the medical evidence alone.
Thank you.
One has to look at those little oddities, little findings, like the interpretations of different findings, like the linkage, like the abrasions around the neck, for the court to arrive at a conclusion.
And also appear to be excluding the possibility of death through throttling, that's manual strangulation by hands or fingers. Why do you seem to exclude that possibility?
Prof. Gordon felt I'm just talking about his view about manual strangulation. He excluded that possibility. He appeared to, or he was of the opinion that was less likely. And I also hold that view that it's less likely because in manual strangulation alone, I would want to see discrete, multiple, individual, separate bruises of fingers, at least about 2 or 3 striking ones. The 2 on the right side, my lord, I indicated that were found were possibly due to that ligature constriction, because the ligature was at the right side. So the pull, the stretch was on the right side. I think that would probably explain that. If I were to contemplate ligature strangulation from the front or from the back, I would want to see multiple and individual, discrete, separate thumb size, fingertip, finger pad impressions on the subcutaneous examination, the layer by layer portion of the underlying tissues. That's where we see it. So we're not seeing that, and therefore I'd like to think that is a less likely possibility. But what is there is the ligature strangulation.
And turning to your paragraph 35, which we've already alluded to briefly, but it is of considerable importance. It cannot be resolutely determined that the ligature constriction of the neck was caused either before or after death,
yes,
or before or after a state of unconsciousness has occurred. Do you wish to elaborate on that?
I think I have covered that, but I can just summarize saying that just on the basis of the findings, there's no way of us pathologists being able to say that the ligature was not placed after death and constricted, or if the person died before, or whether he was still alive and the ligature was placed, or he placed it himself. It's not possible to be very clear about that. The only 2 bruises in the neck were seen just on the inside at the edge of the right jaw and at the edge of anterior front edge of this muscle on the right side, the sternomastoid, this angulated muscle. And those, I feel, are more likely related to the ligature itself. They're superficial. They can be seen, if it's superficial bruises, intradermal or immediate subcutaneous. They can be seen in some cases where a person is strung up very shortly after death.
Yes.
So,
now, Doctor, it seems to me that an important point is whether the deceased was in fact alive at the time of the suspension from the grille door and the application of the ligature around his neck, either by himself or by another party.
yes.
Now, Doctor, you testified in the inquest into the death of Dr. Neil Agate.
Yes.
In security branch detention. And in that case, you were quite certain that at the time of suspension from the grille door, Dr. Agate was in fact alive.
Yes.
Now, in this case, you seem to be saying that Dr. Haffejee was not necessarily alive at the time of the application of the ligature. Can you explain the differences in the two cases and why, in this case, you got the view that Dr. Haffejee might potentially have been dead at that time?
I might not, if I had refreshed my memory of the findings in the Dr. Agate case, I would have been able to give a clear answer to that distinction that I make there. But what I can say is, in Dr. Haffejee's case, the appearances are equivocal. Could be either way. I'd like to think that Professor Gordon would have picked up striking petechial hemorrhages and a venous engorgement with a bluish and congested and engorged face if the deceased was alive. Although that's not always seen, I'd like to think that. But he didn't. He didn't pick it up. And the deceased was light-skinned, furry, relatively. So that should have been a finding he would have made if the deceased was alive at the time of the striking, of the application of the ligature, whether self-applied or not. So it's not very strong evidence that I have to make that distinction.
Okay, I asked the question because of your reference to vital reactions in that paragraph.
Yes.
And my recollection is that in the Dr. Agate case, because of certain vital reactions, it was concluded that he must have been alive at the time of suspension.
Yes.
But perhaps over the lunch adjournment, you can refresh your memory on that.
I'd like to take up that, just see if I can refresh my mind on the other matter. And although I don't have my records with me, maybe you could do that. I could come back to that question.
Yes, I have my laptop, so I have it all available. Yeah.
Okay.
My Lord, my learned junior reminds me that it's 11:15. If your Lordship wishes to take a tea break, would this be an appropriate time?
Perhaps let's do that. Proceed at quarter to then. Quarter to 12. Is that okay?
As the court pleases.
Court is adjourned.
Quarter to 12. We're definitely not finishing at lunchtime.
You're still under formal oath, Doctor?
Thank you, Claude.
Yes, sir.
As the court pleases. Doctor, just before the tea break, we were engaging on the question of the possibility of the deceased being alive or dead at the time of the suspension.
Yes.
And we made reference to the Dr. Neil Agate case. And I understand that during the tea break you had an opportunity to refresh your memory.
Yes, I did.
Please elaborate.
Thank you. Just to describe the difference between the Neil Agate case in Johannesburg, who was found hanging from a very much higher position on the grill door of the cell, and this case, which the court knows the scenario in which he was found, practically lying or on the floor. The difference was that in the Neil Agate case, the two bruises that were found were quite deep in the neck, sorry, my lord, quite deep in the neck, to the effect that one bruise was in the deep carotid sheath, and the other one was on the left side of the hyoid bone. Or was it the right side? Left side of the hyoid bone. Now those bruises in the neck, now much deeper in the neck, after several layers are lifted off, that's when you detect that. And that is usually what you want to believe it is the effect of either deep finger pressure, or in Neil Agate's case, the actual, I think it was the knot, the strip that was, because he was hanging, the strip that passed and compressed against the right side of the neck and caused him to hang. And his head also to, if I recall correctly, correct me if I'm not sure, to be tilted to the left side. So and then those two, the depth of it indicate that they were of course during life, or he was alive at the time that happened. But what clinched that also, that initial impression, what supported it strongly and practically clinched it, was the finding of the subendocardial hemorrhage in the heart, which is clearly something that will occur whilst the deceased is alive but just dying. So in Neil Agate's case, I was able to be very confident in asserting that he was alive at the time of the hanging. In Dr. Haffejee's case, I think the evidence is equivocal and could be either way.
And just to sum up, in Dr. Haffejee's case, he may very well have been dead before the suspension.
Or before the constriction, because there was no real suspension.
Yes, but when I mean suspension, I mean the application of the ligature to the grill.
The ligature strangulation.
Yeah. Yes.
Because I think we can, forgive me, Lord, I think we can call it ligature strangulation. He strangled, whether self-applied or whether by somebody else.
Yes. Now I'm simply referring to the procedure of attaching him to the grill. So your evidence is that there's a possibility that at the time he was attached to the grill, he may have already been dead.
Yes. Yes. Correct.
And in layperson's terms, that's because there are not sufficient vital reactions reflected in the post-mortem report to suggest otherwise?
Correct. That's right.
Okay. If we can turn to the age of the injuries, that's at paragraph 36 on page 14 of both versions of your report. And I think here, because you have already alluded to the age of the injuries, we can deal with this fairly quickly.
Yes.
But I just want to draw the attention of the court to the very last sentence in that paragraph. I'm of the view that what was of most value was the coinciding overlap of the estimates, in that the general wound age was at its widest range between 6 and 24 hours. but there was concurrence of a period of between 8 and 12 hours. So you would agree with me that this places the age of those injuries squarely during the period of his detention?
Yes, and during the period that he was not in the cell. Correct.
Indeed.
Yes.
Indeed. If, of course, we're relying on the determination arising from the rigor mortis,
Yes.
that he could only have met his demise between 10 or 11 or midnight.
Or thereabouts, yes.
Or thereabouts.
Yes.
Yes.
Well, Lord, I just need to state that a lot was covered in the transcript of the previous inquest about the age of the injuries. But I think that was quite redundant because the only thing that is important in the two versions, the versions of police representative and that of Professor Gordon, was that there was this concurrence.
Sorry, doctor. If you place the time of his death between 8 and 12 hours,
Yes.
would that not suggest that he was died before being lodged in the police cells?
That's a very strong possibility, my lord.
Unless the evidence relating to the time he was placed in the cells is in itself not correct.
That's correct. That's right. May I ask, with respect, what time, just to refresh my mind, that the police say they put him into the cell?
So my junior will give us the exact time, but my recollection was that it was
I
close
think it
to
was midnight. Am I right?
Yes.
I think the evidence we have was that it was 12 midnight.
12 midnight, that's my recollection, my lord. So, my lord, the source of that information for approximately midnight is on Taylor's version, and that can be found at volume A3, page 135, and also at PDF page 156, lines 19 to 26.
Yes. Lord, I think what I need to indicate is that when we say 8 to 12 hours, it's wounding period, we've narrowed it from 6 to 24. We've narrowed this to a more likely period of 8 to 12 hours. But that's just the most likely period. We can't exclude injuries before that or exclude injuries after the 12 hours, but the most likely period is that 8 to 12 hours before death.
So if the death occurred at midnight, then we would have to take the 8 to 12 hours back from that time.
That's correct.
If the death occurred at between 3 and 4 a.m., we'd have to take that period back from that
That's
time
correct.
of the early morning.
That's correct.
Can we move to the next point that you make, Dr. Naidu, which is of also considerable importance?
Yes.
And my lord, we're now at paragraph 37 on page 14,
Yeah.
dealing with the injuries of the body's surface and on the scalp of the head, chest, and mesentery. And Dr. Naidu, you say at the risk of being emotive in this description, these would have been particularly significant and physically incapacitating for the deceased.
Yes.
Why do you say that?
Lord, I believe these injuries were very severe. I think it was difficult for the previous witness, Professor Gordon, to be tied down because to give an idea as to severity. And if he repeatedly asserted that he cannot talk about severity, and to the extent that he was not able to exclude the bundling effect into the car. That would be minor injuries. And when I look at this, I find that these injuries, or the implications of these injuries, are very severe. Now, I deferred with Prof. Gordon, and this is the remarkable thing about this very eminent professor of forensic pathology that we've had, in that interpretation here, I believe quite differently. He was the only medical doctor to look at this body in its naked eye real state, and you cannot expect and he's only one to have been able to assess the severity of these wounds. You cannot expect a clinician to comment upon it when the clinician hasn't seen it. And being a doctor, is able to, the areas I differ with him is that he's able to give the court an idea. For example, indicate the kind of application of force it requires to crack a finger or to fracture a finger. There's two different forces. Or to fracture a bone, or to cause an ankle sprain. And by virtue of examples that a court will understand and appreciate and most non-medical persons, give an idea of the kind of impact to the chest or the abdomen or to the back. When I look at this transcript, there is one position, one point in the evidence when they talk about these injuries being very superficial. Naturally, surface injuries are surface injuries, so they will be superficial. But the implications of that impact to the person in terms of causing pain and distress, and that's different. There's no doubt that the fact that had he not been strangled, Dr. Haffejee would have survived all those injuries. He was a young man. He definitely survived with much pain and distress and period. But it's the implications of the effects of those impacts causing those superficial injuries that need to be looked at. Now, those, in my view, are severe injuries. Some of them so severe that they could have themselves have been responsible for the death. Apart from that, they collectively would have been such that the person would have been rendered, as I mentioned, desperately incapacitating, physically incapacitating, in distress, noticeable pain, marked distress, to the effect that the deceased's condition and his state of health would have been evident by any even layperson looking at him. His posture and his ambulation and his ability to stand upright, all those things would have been affected. Thank you.
Right. Thank you, Doctor. And presumably that is why you say in your report, that's in paragraph A of 37, I would respectfully disagree with the Chief Government Pathologist, Prof. Gordon, that expressions of gradation of severity by pathologists are not of value to the court. And I would argue that forensic pathologists should provide guidance to interpretation of injuries in an objective and non-emotive way. What moved you to make that conclusion?
It's my impression that if the forensic pathologist is not able to do it, then I'm afraid the forensic pathologist is probably not serving that role that he should in in a court or for the role that he plays. Certainly, the amount of clinical experience that you have, the more helpful it is. But after all, he is a pathologist that qualified in medicine, and he should give that in non-emotive ways. In other words, indicate by way of examples the levity, the gravity of the force.
Yes, and while we're on the reluctance of Professor Gordon to apply his professional expertise to the issues at hand, I just want to read you a rather startling passage from the finding of Magistrate Blunden. My Lord, this is in volume A2 on page 14. It's about halfway down the page. And Magistrate Blunden writes, Professor Gordon, who had heard the whole of the evidence of Captain du Toit and Lieutenant Taylor and Dr. Lawrence, who had heard the salient parts of that evidence, were both asked to comment on the probability of the deceased's injuries having been sustained in the manner postulated by the two policemen. And you will recall that the policemen claimed that the injuries were sustained when Dr. Haffejee resisted arrest and had to be forcibly pushed into the vehicle, as well as at an alleged pointing out the same thing happened. And here's what I want you to comment on, Doctor. Professor Gordon refused to comment.
Yes.
He was not prepared to express an opinion as to the mechanism whereby the injuries in question may have been caused, nor was he prepared to make a scientific assessment of the degree of force required to cause them. He then says a layman was, in his view, in as good a position as any medically trained person to make assessments of this kind. Doctor, I find the refusal of Professor Gordon to give his professional medical view to such a critical question is just astonishing.
Yes, I would agree. Almost adding, I would add that even as a layman, if Prof. Gordon took off his medical cap and set it aside and viewed these injuries as a layman, a non-medical person, he should have come to the conclusion that these were severe injuries on their own.
Yes, well, certainly from the perspective of the family, we find it regrettable, to say the least, that a leading forensic pathologist declined to assist the court on such an important question, given his experience and qualifications. But moving on, Doctor, if we can turn the page of your report to page 15 at the top. You say most forensic pathologists would be confident in specifying that the skin injuries in this case are significant and were caused by more than moderate degrees of force, and that the scalp and thoraco-abdominal wounds were caused by an even more significant degree of force, as would be sustained in impacts that can normally fracture bones or rupture an organ or intestine. So that's yet another conclusion that you appear to be disagreeing with from Professor Gordon's finding.
Yes, correct.
Doctor, if we can move on to the head injury, and we have alluded to this injury yesterday. This is the scalp injury, the extravasation of blood into the subepineuritic space, or hemorrhages, and may simply be called deep scalp bruising. Can we can we deal with this in a little more detail? Because it appears that you're concluding that the effects of this injury could have been potentially serious for the deceased.
Yes, I can paraphrase what I'm saying here. First of all, Professor Gordon himself, in his record and in his testimony, described it as extensive. But later on, when he read his report, later on in cross-examination, he refused to be drawn on whether these, he completely excluded a post-mortem occurrence. So I found that very strange from a very experienced forensic professor, that he would not be, when he calls deep scalp bruising extensive, and in a body that is so freshly dead. It was a Muslim body, so he's doing the post-mortem the same day, which he could have delayed, but he did it the post-mortem same day. There is virtually no chance of post-mortem change, decomposition, where the decompositional change turns things bluish, reddish blue inside and black. So in other words, he couldn't have mistaken this deep scalp bruising for post-mortem change. So I find it very difficult to, whether or not there was a discussion that the blood can move about of the scalp, whether or not it could. The point about it, he should have been very strongly assertive that this was deep scalp bruising and this was ante-mortem. In other words, occurred while the deceased was alive. And the other thing about it is that, and in this paragraph that I deal with, is it's unheard of. You see, although doctors don't go around pushing people into vehicles as part of their job, to know how people, forgive me for elaborating on that, my lord, to know how people can injure their elbows or whatever if they're forced into vehicles. But I think any lay person, but more so a medical person, like Prof. Gordon or myself, can say it is highly unlikely to get such deep scalp bruising in pushing someone into a car, even if they had to bump the roof or the back of the seat or the side of a seat or the other side door. It's highly unlikely to get deep scalp bruising of this nature.
And
I think that's...
And indeed, in this paragraph B on page 15, you suggest that the more likely possibility that it was from several physical impacts that rendered the bruising as a confluent set of hemorrhages.
Correct.
And that's almost impossible to have occurred from entering a vehicle.
Correct.
If there were multiple impacts.
That's correct. And remember the caveat that the only other thing that could cause it was a bleeding tendency like hemophilia or the bleeding disorder, clotting defects. Was somebody like hemophilia who's got leukemia or such with very low platelets. Those people spontaneously bleed, or people with what they call ITP, thrombocytopenic purpura, very low platelets. They are hematological disorders.
But there's no evidence of that in this case?
No, nothing of that in Dr. Haffejee.
Yes. So what would the impact have been on the deceased after receiving those physical blows to the head?
I have consulted verbally with a neurosurgeon on this, my lord. It was the day before yesterday, before I came to court, just to canvass that, because I realized that I might be asked, because I mentioned concussion. And he said, well, if you're going to look at that, look at the possibilities of what impacts were caused. The multiple blows on the head with a static, unmovable head is one, but you cannot exclude than knocking against the wall or being thrown against a wall or thrown on the floor or pushed over by the chair or kicked. There's one account where he was kicked on the buttock and he struck a pillar on the other side. So the neurosurgeon suggested that you cannot exclude concussion. Concussion is a stunned state of disorientation and abnormal neurological behavior. And in that time, you can be, don't have to lose consciousness, but you can have a state of concussion. Or you could have been rendered unconscious with those impacts. So one cannot exclude that.
And if he had been rendered unconscious, how long potentially could he have remained in a unconscious or concussed state?
That would be a clinical question, but I believe that concussion, if one renders someone unconscious with head impacts, it can range from a few minutes to several hours. It can range from from a few minutes to several hours. I would think. I believe so. Yes.
And if someone is in a state of unconsciousness, can one somehow intervene and bring him out of that state quickly or not?
No, usually they cannot be aroused because that's a physical injury, and you've got to. It's causing neurological paralysis in the brain, so you've got to wait for that period to pass. So you can't rouse someone to a state of consciousness, fully awake and alert from a state of concussion.
So not even throwing water on the person would help?
It would have no effect at all, really. And
what is the possibility of brain injury arising from such a blow to the head?
The brain injury we talk about are three types. First of all, bleeding into the brain, into the cranial cavity, either extradural or subdural or subarachnoid, and depending. For example, if it was an impact that fractured the skull, you'll get the extradural type. But if it was impact that threw someone against a wall where there's a mobile head, see the fixed head and a mobile head, the mobile head gives you the subdural. So none of those were found. Oftentimes you can get direct contusions of the brain, and they're usually associated with fractures or severe localized impacts. But of course, in this case, we didn't find any. But you do not have to find physical, visible injury to the brain in the case of head impact with concussion. In fact, it's more the rule that you find no brain injury visibly with patients with concussion.
Are you saying that there is the possibility the brain injury was happened, but it couldn't be discerned at the post-mortem?
That's correct. That's correct.
And if brain injury had occurred, even if he was able to emerge from the state of unconsciousness, then they wouldn't have been able to perhaps even get him to stand up and walk.
Oh yes.
He wouldn't have been able to talk.
Oh yes, he wouldn't have been able to function normally in a state of concussion.
And that possibility, there would have been no way for Professor Gordon to have made a determination of brain injury at the post-mortem. It simply wouldn't have been evident from a visible inspection of the brain.
Correct. You see nothing on the brain surface in most cases of concussion. Even under the microscope, you may, more often than not, you see no evidence of injury.
So the possibility of Dr. Haffejee being brain damage following these blows to the head cannot be excluded.
Functionally, brain damage from a state of concussion, yes, one cannot exclude that.
Now, you make reference to the fact that the magistrate in his judgment, and Lord, that's, I believe at page 10, or that might be 110 of the finding, speaks of the deceased having a thick mop of hair, which could have had a cushioning effect on any blow. Doctor, I find that a curious statement by the magistrate to suggest that if he had received blows to the head, it perhaps wasn't so bad because of this cushioning effect. Is there any merit in that suggestion that the head would have been protected by thick hair?
There's no there's no substance to that assertion, my lord. It's frankly a wrongful understanding of the effects of a thick mop of hair. May I respond on that to say that from my reading, Professor Gordon replied to that assertion or suggestion that he could not make a finding on that, could not comment on that. He didn't know anything about or much. Oh no, that was hair pulling. I acknowledge. I think I might be making a mistake. That was of the pulling of the hair. I think regarding the effect of the cushioning effect of hair, Prof. Gordon, I think he replied in and acknowledged that it's possible. But the only thing that a thick mop of hair does, it diffuses the impact so that you don't get a tear or a laceration or a cut or a split in the scalp with a blow. So that's what a thick mop of hair does. Apart from hiding the injury, you just see blood, but you've got to delve through the forest of hair to find an injury and stitch it up. That's what we doctors do. But what it doesn't do, it doesn't cushion the effect of the impact on the brain. So in other words, the jarring jolt of an impact is still felt by the brain. So the cushioning of the hair simply prevents and diffuses the surface injury, so it makes it difficult to tear the scalp or to find the scalp tear, but you will get bruising and you still will get brain jarring injury that causes the concussion or can cause the concussion.
And Doctor, on that score, when Professor Gordon was being cross-examined by counsel for the family, Mr. Cooper, he conceded that the hair was not shaved for the examination. Should the hair, in fact, have been shaved for the post-mortem examination?
We often do, and if there's any question about the presence of injuries, we would. It's advisable that it be done. For example, it's a decision that we take at each post-mortem. For example, if there's a gunshot wound in the scalp, I would say it's mandatory to not only shave the hair, but to retain the hair just at the entrance so that can be sent for ballistic testing to see if there's propellant to tell us whether it's a close-range injury. So that's sort of a way. In a case like this, it is often found that we dispense with shaving if we're able to examine through the hair carefully. we can, so long as we make out that there's no surface injury, what we want to see is the amount of scalp bruising or whether there's a scalp fracture underneath. So shaving is not mandatory, but it helps very much where there's a suspicion of an injury.
And would there not have at least have been a suspicion of an injury in this case, given that Professor Gordon had discovered the scalp injury of extravasation of blood?
Yes, but on, if I may say, on palpation and examination of the scalp, you can pick up most injuries. I must agree that if there was, for example, a suggestion that an iron rod was used, a rough, rusty iron rod was used that also abraded the scalp, I would say let's shave the scalp in order to display that sort of pattern of injury. I would certainly agree with you. But it's a decision taken by every pathologist at the post-mortem.
Can we turn to the injury?
Hence the history, just to finish that, the history that the pathologist gets is so critical because it guides the technique and is procedure. It can guide that procedure. For example, just another example, my lord, if someone says, or if they got a history that the deceased was slapped on the face, on the ear, then it's a good idea to look with an otoscope, look at the eardrum to see if the eardrum is not ruptured. So the history guides very much the finding, the procedure.
And would it be true to say that when we talk about history guiding the examination, it would be the history of the incident in question,
yes,
but also the general history, the general context. And by the late 1970s, I would have imagined that somebody in Professor Gordon's position would have been aware that detainees and those in police custody would often turn up with injuries
yes,
sustained during custody.
yes.
And so there should have been a heightened awareness on his part.
Oh yes, without a doubt, at a senior level and a senior government pathologist, yes. The senior government pathologist.
Yes. So then if we can turn to the injuries on the chest, and that's in subparagraph C on page 15 at the bottom of the page. Here you also talk about potentially serious injury, which you describe as thoracic contusion, that's bruising, which you say is indicative of a heavy blow to the left lower front of the chest. Why did you regard this particular injury as so serious?
The position of this injury on the left lower front of the chest is almost on the position, cardiac position, the heart's position. And bearing in mind that it's a 26-year-old male at that young age, his ribs and tissues are very pliable, they're very flexible, they're almost like elastic. And it gets a bit, all our bones and tissues and ligaments get a bit stiffer as you go older, and ribs get a little bit less rigid and more prone to fracture. So to cause a large bruise, and that was a significant size bruise on the left side, that would have been a significant blow. And any person, if he was 47 or 46 or 56 instead of 26, there would have been fractures in that position, likely been fractures in that position. Now, its proximity to the heart is something that made me concerned about the possibility of a cardiac concussion or cardiac contusion, but that is visible. But you get such a thing called a cardiac concussion, which is, you remember the brain concussion, but this here is also similar in that it can functionally dysregulate the heartbeat, so that the person forgive me, Lord, such a blow to the heart can cause what they call, it's called commotio cordis. You can get a functional dysregulation of the heart, where the heart goes into either an abnormal rhythm or can suddenly stop. So that's a possibility. Look, it's not common, but that's a possibility. The other thing is, on the left side, and I did mention in my report, it's of close proximity to the spleen, but the spleen hasn't ruptured here. But it's a bit away from the abdomen. So I think that the abdominal injury, which I'll come to probably shortly, is a separate injury. There is a possibility, therefore, that that left chest injury could possibly have been a cardiac cause of acute cardiac death, and in fact, Professor Gordon alluded to that in his testimony at a point, calling it acute neurogenic cardiac failure. I saw it when I went through this morning.
Do you have the reference for that per chance, Doctor?
Okay.
If you have a page number, you can give it to us. If not, not to worry, we'll find it. You don't have to find it now. We'll deal with it in due course.
Okay. That may have related to the. Forgive me, Malot. That may have related to the mesenteric. It's definitely there. Acute neurogenic cardiac failure may have related to the mesenteric contusion, the abdominal injury, and not the cardiac injury. I'll have to just check that one.
Okay. My junior will find that reference.
Sure.
By Professor Gordon. So, Doctor, the possibility of sudden death by the, as you said, the trigger of a sudden abnormal cardiac rhythm, that is not necessarily, on the objective evidence, incompatible with the death by strangulation. So in other words, I suppose what I'm getting at, both are possible in this case. One doesn't exclude the other.
Oh yes, it is possible. In other words, is suggesting that he could have had a severe blow and survived that with bruising, of course, and then after that be proceeded to the ligature strangulation with a homicidal suicidal. That's possible. Or it could have been a cardiac cause of death or cardiac arrest, and then the procedure of strangulation. Both can be possible, yes.
Right. Could we then move to the abdominal injuries?
Yes.
And again, if you can, also explain the mesenteric extravasation of blood and why this is also a very serious injury.
Yes. The mesentery, if one imagines what the intestines are like in the abdomen, all lying loose and movable, but each coil is still attached by an apron. The coil of intestine, as it goes, has its apron attachment, and that's called the mesentery. The bowel is not loose; it's movable and mobile, but not loose, or not detached to be loose coils. They're still attached by a mesentery, a little apron. I mentioned yesterday that the abdominal wall won't manifest with injury but transmits injury internally. And what happens with a blow, if there's no solid organ, liver or spleen rupture, what happens with the blow, it creates the sudden increase in intra-abdominal pressure because it's a closed cavity. A sudden increase in pressure wrenches tissues from attachments. It wrenches tissues from attachments. You can get a popping of the bowel, or you can get a tearing of the mesentery, because the gas-filled bowel often half full with gas, half full with solid material, it blows up in little balloons, but it will rupture or tear at the most vulnerable point. But to do that, my lord, that the blow has to be, to cause a mesenteric injury, at least a contusion, it has to be a significant blow. It's got to be a very hard blow. In fact, Professor Gordon used the word significant. He agreed that it could, he acknowledged, and I can give that reference shortly later, he acknowledged in his testimony it could be due to a booted foot or a fist. About repeated blows, he was unable to say, but I can comment on that. He did acknowledge that it would cause him to double up and in pain, can wind him. And Professor Gordon, in saying that it is a significant injury due to the application of force, he brought up this acute neurogenic cardiac failure. Okay, the cardiac effect. Any blow to the abdomen, when causes someone to wind up, it's the effect on the solar plexus, we say. It's a neural effect in the solar plexus. It actually can cause the heart to stop beating. We spoke about the heart stopping beating with pressure to the carotid body, but it can occur with an abdominal blow as well, especially a higher abdominal blow closer to the heart. So this is a very significant injury, my lord, and I would equate it, its significance, to using to be booted into the abdomen, or kicked into the abdomen, or sometimes with a heavy knee blow, less likely, into the abdomen. I've seen it occur, and I have seen the injuries from blows to the abdomen like this. And I can say this could be as described as a mule kick.
Right.
It could be multiple. You can't exclude that, although there's no way of saying. And I would just put it to the court's assessment as to, if you got one blow to the abdomen, you probably could have had several lesser magnitude blows before this final blow. That's also a possibility. Or it could be a single one.
And you mentioned in this paragraph, Doctor, that the impact of this assault could have been potentially dangerous and even life-threatening had the spleen or liver been damaged. And you go on to say that it must be borne in mind that if there was no observable bleeding, death may have supervened very shortly after the abdominal impact, and this may actually suggest that the death may have been caused by the chest abdominal impacts themselves.
Yes, my lord. I drew that observation because, although it's qualified that we don't know the size of that, what I do know is that with a mesenteric contusion, you should get bleeding. You want to expect bleeding, free bleeding, some free bleeding. So because it was not present, I'm just raising the possibility maybe death occurred very shortly before he had a chance to bleed fully. Unlike the scalp injury or those of the body, where there was enough vital reaction to manifest. We're talking about vital reactions here, the reaction of the body to injury, to bleed out, to bleed into the tissues, to become a bruise. So if it was so significant on the scalp and the rest of the body, but minimal of the abdomen, I'm just drawing that likely possibility. I don't know how likely it is, but I'm drawing the possibility that this could have occurred just shortly before death.
Right. And again, with our exchange on the other possibility of an earlier death arising from sudden cardiac concussion,
Yes.
a possible death arising from blows to the chest and abdomen is not incompatible with the other possibility of death by strangulation. In other words, they're not mutually incompatible possibilities.
So can you just repeat that, sir?
Well, just on the objective evidence,
Yes.
given that it's already your evidence that the deceased may have met his demise through strangulation,
Yes.
but you're also raising the possibility that he may have met his demise earlier through death being caused by the impact to the chest and the abdomen.
Yes.
So on the objective evidence, it's not that it can only be one and not the other. Both are possibilities.
Yes, no, both are possibilities, yes, definitely. So you can't, obviously, if he died as a result of that severe abdominal blow, the chest blow, then he would have been dead at the time of the ligature strangulation.
Yes.
So these possibilities are something to consider. I'm not saying that, for example, that he did die of a blow to the abdomen. I'm saying that we must consider that. And I'm not saying that he didn't survive for a while with that abdominal impact. I think what the court must look at, with that degree of injury to the abdomen, that would have been heavily incapacitating. So I don't think he would have been able to walk with that impact. He would have been winded and in pain and on the ground and crouched.
And on that score, let's now move to the what you call the general effects of the injuries.
Yes.
And perhaps let's start with the impact or effect by the injuries to his abdomen area, the mesentery. You say it's unlikely he would have been able to walk normally.
Yes.
So if there was evidence before this court that he was able to walk normally up in an upright position from the interrogation room to the charge office and then to the cell, in your view, that probably is unlikely?
Yes, unlikely to have had that injury at that time. So the injury to the abdomen could have been more likely subsequent.
Yeah.
To
Let's assume that the interrogation had ceased by that time and the assault had already taken place. In those circumstances, what is the likelihood of him being able to walk unaided and upright?
Oh, I think if the evidence of the observers were true, were so, I would very much doubt that was true. Any observer would have seen that this deceased, at least Dr. Haffejee at that time, still alive, would have been unable to walk in an upright position. He would have been half bent over in pain if he was able to stumble along.
And indeed, in paragraph E on page 16, you call into question the police evidence that when the cell was visited at 0300 hours, he was awake and normal.
Exactly. Yes, that's correct. I I'm seriously calling into question the awake and normal description at 0300 hours. If he was brought back to the cell after interrogation, because by that time he would have definitely had all those injuries and a severe abdominal and chest injury, if not already unconscious by the head and scalp injury.
Yes. And indeed, as you state in that paragraph, he may very well have already been deceased.
He may well, yes, that's correct.
I think we can skip the next
testimony of Prof. Gordon, which I cannot reconcile, really. Bearing in mind that Dr. Biggs talks about those injuries that are unusual and feels it's like injuries caused on the skin by lead seals being compressed, you know, and I alluded to the picture of children playing with coins and freshly made dough or paste. Well, not dough is best because you create beautiful impressions of anything that you place it with, like with coins. Now, that is a striking finding. Professor Gordon also, in his testimony, said that the injuries were, I don't know if the word is correct, remarkable, unexplainable, because it talks about them like a dye effect. You know, dyes, D-I-E, where you make dye impressions of something. And that the wounds of the back were rectangular. And remember that they were at the recesses. And I think I need to say that any pushing of any person into a restrained orifice, like an opening, like a car door or a door of a room or a cupboard, the positions where you would see injuries would be at the areas of impact, which would be on the face, on the sides of the head, shoulders, elbows, sides, and perhaps knees, and that's about it. But the cluster of injuries here, the cluster patterns in the recessed areas, in a patterned impression around the elbows and the knees, which Prof. Gordon actually alluded to. He says those injuries that he can't explain, they just do not fit that idea of bundling. I can be bundling, I'm using the word bundling because you bundle people into vehicles, you push them in, or even use your boot and push them in, like sad movies or comics. So I think I need to strongly make that point that I cannot understand why Professor Gordon was not able to at least indicate the weight, at least the leaning of his general opinion, whether or not as a layperson, but more as a forensic pathologist, that this pattern, there's no pattern matching here of the incident and the dynamics of the incident to what you're seeing on the body. It just doesn't fit. Yes. For several reasons, for so many positions of injury.
Yes. Well, Doctor, we will be advancing arguments in that regard in relation to the reluctance of Professor Gordon, although we won't do that at this stage. So, just to sum up, you can fairly safely exclude the possibility of the visible injuries discovered at the post-mortem arising from the so-called bundling into the vehicle.
Yes, I would like to exclude that.
Yes.
Completely.
So then, unless there's anything else, can we move on? Yeah. Okay. Then let's move to the point that you make at paragraph 39, that the deceased was to a great probability unclothed at the time of the injuries, particularly the limb and surface injuries, and at some point before his death walked barefoot. Why did you reach the conclusion that he was probably unclothed at the time the injuries were effected?
Well, in retrospect, reconciling the number of injuries, and as you know, I personally counted between 60 and 75. I think Professor Gordon talks about 40 to 50, and somebody else talks about 50 something. I would have expected the clothing to be heavily bloodstained, because these were aberrated bruises, and aberrations bleed or ooze a serum. When the plasma proteins separate, it becomes a bloodstained watery ooze. That's called serum, and that readily stains clothes. The deceased apparently was, and I think we can confirm it by some of the pictures, the clothing were light colored. Someone said, I think I recall overhearing at the visit to their own local inspection, the one witness says he wore a safari suit. That may be so, but I think we're looking at a shirt and a pants here, light colored, and one would expect to have seen that. Seen the clothing heavily bloodstained, visibly heavily bloodstained. But it's not really reported, so I'm not too sure. I mean, Professor Gordon didn't report on the clothes. What happened to the clothes, we're not too sure. I know what I believe is, and what is the practice, and what I've always argued, is before the pathologist arrives at the mortuary, the clothes are ripped off the body, just to make things easier for the day's work. And that is a practice, my lord. Sorry. And as much as I protested against that, sometimes it just still continues, because you had no control over the administration of the mortuary, you just were the medical person.
Yes.
So that may be the reason. Secondly, Dr. Biggs reported that the soles of the body the deceased soles were very, very grimy. But when on the photographs, there's no grime on the rest of the body. The rest of the body is clean. So I believe at some stage or some degree of time, he was walking barefooted.
On a particularly dirty surface?
On a dirty floor. Maybe including walking from the interrogation room to the cell on the whatever
yes,
roadway.
We don't have to speculate in that regard.
Okay, sorry.
Dr. Naidu, we've already heard evidence from another detainee, Mr. Govender, that he was also stripped naked, and we will be putting similar fact evidence before this court from other detainees who will testify of similar treatment. And we will certainly be suggesting to this court that detainees were often stripped naked in order to avoid blood being left on clothing. And on that score, I wish to refer you to an extract from the transcript of the first inquest. My lord, that's in volume A3 at page 63, towards the middle of the page. And it's an exchange between Mr. Cooper, representing the family, and one Brigadier Lothar Neetling, who was the forensic expert for the police. And just to cut to the chase, Brigadier Neetling was involved in testing the clothes, or sending the clothes for testing to see whether there were traces of blood on them. And so Mr. Cooper says, in the middle of the page, could we please put them in an envelope? It will probably be desirable, which in fact consists of 4 pieces. Were they tested for the presence of human blood? And Netling says, this is correct. And we're actually translating from the Afrikaans into English. Did you find any blood on any? And Netling says, we have all the clothes examined for blood, and we have cut out these specific pieces because the reaction carried out with the preliminary examination for blood on those specific sites seemed the most promising to perhaps get enough material for the detection of human blood on the material. However, it was not shown to be human blood on this material. However, the presence of traces of blood is no longer sufficient for a determination to be made to determine human blood unambiguously. And then a bit further down, it's put to him, in short then, your tests for the presence of blood on the pieces of cloth were negative. And Netling's response, for the indication of blood, the test was positive. And that's, I think, important to note. Namely, the test performed roughly indicates if there's any bleeding with luminol. It is a very specific reaction used. The whole garment was sprayed with it, and we got somewhere there could have been possible blood, but the further extraction for which the pieces were then cut out to then unequivocally prove that it was human blood was negative due to the extremely low cone concentration of blood that was present there. So from that extract, it seems that Brigadier Netling, on the one hand, was accepting that there were blood traces, but of a very low concentration. But are you somewhat surprised to hear that evidence from Brigadier Netling?
Very surprised. The only explanation for that would be where the clothes were put on at a later stage, probably after all his injuries had been sustained. And also when the surface abrasions had dried out after a short while and they're not actively bleeding, to get minimal blood on the clothing. For example, if I may, in the testimony of Prof. Gordon, he says he lifted up the shirt and he pulled down his pants and he was examining his pants. I assume his short pants, or his boxers or briefs or whatever, and his shirt were in place, according to Prof. Gordon. He picked it up, but there's no way where that he states that it was heavily bloodstained. So the only explanation I thought might be possible, if that was not blood, and I'm contesting that, if it was not blood, was that the clothing was replaced upon the body after a short while after the injuries.
Is it possible, Doctor, that when you speak about the blood stains were somewhat dried out, so the clothing might not have become stained, is it possible that the blood could have been wiped before the clothing was placed back on?
That's quite possible as well. All the free-lying blood wiped off. We've done that before. I've done that at an autopsy to examine it properly, so I know how to do it. And it is possible that there's no active bleeding, and there's a rapid congealing, rapid clotting with dry appearance of the abrasion fairly quickly. So that may be the explanation for that.
Yes, indeed. And I'm told it is 1 p.m. There's still a few matters I want to canvass with you on the question of blood, but my lord, would this be an appropriate time for the lunch adjournment?
Yes, let's take lunch adjournment. We proceed at 2 o'clock. Court adjourned.
Thank you.